serious condition, and so it is important to understand how it occurs and what clinical features are commonly associated with it. So let's get started. So multiple sclerosis is a chronic immune-mediated inflammatory disease of the central nervous system. Pay attention to the word or the phrase immune-mediated, because it's an inflammatory disease caused by some immune reaction, and it is going to be characterized by demyelination, axonal injury, and neurodegeneration. Demyelination meaning loss of myelin sheaths. So it ends up affecting the brain, the spinal cord, and the optic nerves, with the lesions disseminated in time and space. And this is really the clinical characteristic. The lesions disseminated in time and space. So for pathophysiology, regarding etiology and risk factors, multiple sclerosis arises from an interaction between the genetic susceptibility and the environmental triggers. Genetic factors, there are a strong association with the HLA-DRB1, and then there's increased risk in first-degree relatives, specifically. So these two factors can lead to increased risk of multiple sclerosis. And then environmental factors include Epstein-Barr virus, infection, and then vitamin D deficiency and low sunlight exposure. Smoking is another major environmental risk factors. And there's actually higher prevalence of multiple sclerosis cases in temperate climates. So basically, the further away you are from the equator, the more likely you'll be susceptible to multiple sclerosis. It's a very interesting observation that an epidemiologist made. Anyways, let's talk about the immunopathogenesis. So for immunopathogenesis, the multiple sclerosis is primarily a T-cell mediated autoimmune disorder with some contributions from B cells and innate immunity. So what happens is that first there's a breakdown of the blood-brain barrier. So we have activated CD4 plus T helper cells like the Th1 and the Th17 that cross the blood-brain barrier, and then the blood-brain barrier permeability will increase due to the cytokine release. And then the second step is the immune cell infiltration, where within the central nervous system, the CD4 plus T cells will secrete interferon gamma and interleukin 17. The CD8 plus cytotoxic T cells will directly damage the axons. The B cells will produce autoantibodies, and then the macrophages and the microglia, which probably can be signaled by the interferon gamma, will end up phagocytosing the myelin, ultimately leading to its damage and destruction. And of course, the final step is myelin and axonal injury, And so acute plaques will show inflammation, while chronic plaques will show gliosis and axonal loss. Alright, and then finally we have neurodegeneration. So, regarding this process, it is not solely inflammatory, but the progressive axonal loss will contribute to brain atrophy and a permanent disability. So this explains progression in later disease even without the active inflammation. And then here's a nice picture that outlines or breaks down how we get from the triggers of multiple sclerosis to immune triggering in the periphery and then to immune cells accumulating near the blood-brain barrier before crossing the barrier. And then how this leads to inflammatory reactions, ultimately leading to demyelination, eventually neurodegeneration. So, let's move on to talk about the clinical features of multiple sclerosis. Regarding the pattern of disease, the symptoms depend on the lesion location and will classically show relapses and remissions, symptoms separated by time and affecting different central nervous system regions. And remember when I said that the lesions are separated by space and time? That is basically the primary characteristic of multiple sclerosis. So once again, there's relapses and remissions. Symptoms will be separated by time and space. And then for common presenting symptoms, we have visual disturbances like optic neuritis. The optic neuritis happens to be the common first presentation. It involves painful monocular vision loss, decreased color vision, and relative afferent pupillary defect, or RAPD. Relative afferent pupillary defect, so please remember that. We also have motor symptoms like upper motor neuron signs. So classically speaking, upper motor neuron signs include spastic weakness or muscle spasticity, hyperreflexia, clonus, and then Babinski sign. And this is where if you use the pointed edge of the reflex hammer and stroke the patient's plantar side of the feet or the soles of the feet, their toes end up curling up rather than down. And that's the Babinski sign, or the positive Babinski sign. And if for motor symptoms, the lower limbs are usually affected. And now we have sensory symptoms like numbness and tingling, loss of vibration or proprioception sensations. We also have different sensory levels that could be affected, although typically the spinal cord lesions are the ones most involved. We also have Lermite sign, which is the electric shock sensation down the spine on the neck during the neck flexion. So if you bend the patient's neck forward or bend their head forward, they're going to experience some electric shock sensation going down along their spine. That's called the Lermite sign. Then we have the brainstem and cerebellar features in multiple sclerosis. So, the first one being double vision or diplopia, and this is due to the internuclear ophthalmoplegia. We also have nystagmus and an ataxia or loss of central coordination, dysarthria or pain upon movement of jaw sensations of fatigue, and fatigue can be very severe. And there's this phenomenon called a tau phenomenon, where the patients have increased sensitivity to heat because of some neurological lesion. So be mindful of that. And then some cognitive and psychiatric features are important because psychiatry and neurology are very intertwined. So they can include impaired attention and memory, depression, and emotional ability. So now that we explained all that, let's just review the clinical subtypes of multiple sclerosis. So the most common one is relapsing, remitting multiple sclerosis, where the symptoms and signs of multiple sclerosis occur and then they stop occurring, and then they occur again, and that is known as relapsing, and then they slowly stop occurring, and that is known as remitting. We also have secondary progressive multiple sclerosis, which is involving gradual progression after the relapsing remitting multiple sclerosis. We also have primary progressive multiple sclerosis, which involves steady progression from the onset. And then we have progressive relapsing multiple sclerosis, which is rare. And then the key exams and some clinical correlates to know are that it is a central nervous system disease only, so usually no peripheral nerves are affected. The symptoms will become worse with heat or fever, and there's going to be dissemination in time and space. Testing for the oligoclonal IgG bands in the cerebrospinal fluid can help to support the diagnosis. And on MRI, you'll likely find a periventricular plaques, which in multiple sclerosis cases are known as Dawson's fingers. And here's an image, an MRI T2 weighted image showing the Dawson's fingers, where you can see some white opacities along the ventricles here. And that is why they're known as periventricular plaques. And in this location, they happen to follow the medullary veins. So notice how they're perpendicular to the ventricles. So that's how you know that these can be described as Dawson's fingers, and that the patient in this case will most likely have multiple sclerosis. So in summary, the pathology of multiple sclerosis involves immune-mediated demyelination plus axonal loss. The cells involved include the CD4 plus T cells, the CD8 plus T cells, the B cells, and the macrophages. The lesions involved include the central nervous system plaques and the white matter of the brain or spine, and the core symptoms involve visual, motor, sensory, or cerebellar symptoms. Another reason why the lesions will occur in the white matter is because the white matter of your nervous system is the part of the nervous system that contains myelinated neurons. Anyways, the disease course can be relapsing, remitting, or simply progressive. And the classic hallmark for multiple sclerosis